Welcome everyone. In this section of the lecture, we will be discussing Ewing sarcoma. So for this lecture, we will build upon our knowledge of the basic structure of bone and the function of the main bone cells, the bone remodeling process, and the role of immunomodulators and signaling processes to gain a deeper understanding of the molecular pathogenesis of some of the more commonly known bone diseases, starting with Ewing sarcoma. Importantly, for the learning objective, you need to be able to describe the etiology and pathophysiology of Ewing sarcoma. Starting with a brief overview, what we know about Ewing sarcoma is that it is a highly metastatic form of sarcoma, so a form of bone cancer with the potential to spread within the body from that primary tumor site. It is the second most prevalent primary malignant bone tumor in children and is most common between 10 to 20 years of age, with the median age being 15 years. It is rare in African American and Asian American populations, and the male to female ratio is typically 1.5 to 1. So firstly, we are going to focus on the etiology of Ewing sarcoma. So sarcomas are bone tumors that can be divided according to their genetic determinants. Firstly, there are sarcomas characterized by a complex karyotype resulting from different mutations and severe genetic and chromosomal instability, such as osteosarcoma and chondrosarcoma. Then there are sarcomas characterized by recurring tumor-specific mutations, such as Ewing sarcoma. So Ewing sarcoma is the result of a specific chromosomal translocation between the 5' terminus of the EWSR1 gene on chromosome 22 and the 3' terminus of the gene encoding the FLI1 transcription factor family. So this results in the fusion of a chimeric protein known as EWS-FLI1 that acts as a potent transcriptional activator. So remembering that transcription factors are proteins that regulate the transcription of genes. So this potent transcriptional activation results in an oncogenic function, meaning that it has the capability of inducing tumor formation. So importantly, you need to be able to describe the specific chromosomal translocation that occurs with this disease. So a common mechanism of tumor development and progression of Ewing sarcoma is the dysregulation of receptors for growth factors. So growth factor receptors are cell surface proteins with ligand-dependent tyrosine kinase activity. So dysregulation of growth factor receptors leads to abnormal and dysregulated cell proliferation. It is important for you to know that in Ewing sarcoma, dysregulation of insulin growth factor 1 receptor is central to disease progression. So to provide context as to why this is important, an IGF-1, IGF-1R autocrine loop exists in Ewing sarcoma, where IGF-1 is a direct target upregulated by the EWS-FLI1 fusion protein. So in addition, the transcription of negative regulator IGF binding protein 3 is repressed by EWS-FLI1. So this results in a low IGF-BP3 IGF-1 ratio, which has been described as a marker of tumor progression and poor prognosis. So Ewing sarcoma cells have increased IGF-1R signaling compared to normal tissue, making them specifically sensitive to IGF-1R signaling blocking. And Ewing sarcoma cells also express platelet-derived growth factor receptor beta, which contributes to tumor proliferation and metastases. So, in terms of the pathophysiology of Ewing sarcoma, clinically it presents as bone pain that can be intermittent over several weeks or months. And typically on physical examination, an enlarged tender bony prominence or a palpable soft tissue mass, which may feel warm or appear erythematous, may be apparent. So, intermittent fevers, elevated erythrocyte sedimentation rate, raised white blood cell count, and anemia that is present in Ewing sarcoma also mimics osteomyelitis, which is the inflammation or swelling of bone tissue that is usually the result of an infection. So, correct diagnosis of Ewing sarcoma is time sensitive due to the metastatic nature of this disease. So, we don't want to be treating this disease that has a high metastatic potential as a bacterial infection, as studies have shown that survival rates significantly decline once the disease metastasizes. So internally, it affects the axial and appendicular skeleton with equal frequency and is usually located in the metaphysis or the diaphysis of long bones. A primary site of bone disease is the lower extremity, but it also occurs in the pelvis, chest, spine, and skull. There may be large adjacent soft tissue masses and cortical destruction. And also common is spread through the Haversian canals, which are the tunnels in the cortical bone that house our nerve fibers and capillaries. And importantly to note is that microscopically, this disease presents as densely packed, uniform, small, round blue cell sheets. So, this final slide provides a visual representation of the underlying pathophysiology in relation to the radiological findings and the histology, with the poorly differentiated tissue consisting of small, round blue cells. And that is it for today. I would like to thank you very much.